very distinguished speaker today, a very close friend of ours, and also a distinguished scholar, a health professional par excellence who has contributed tremendously, not only in public health sector, but also in raising awareness about diseases at community level. So his personality is multifaceted, and his contributions spread over a wide range of activities. Very pleased to introduce Professor Dr. Wasim Jafri. Dr. Jafri is associated currently with Khan University, which is a very prestigious health science university, and he has been associated with this institute since 1987. He is a professor of medicine and consultant gastroenterologist and hepatologist. He had been the chair of medicine and section head of gastroenterology, and was also the founding associate dean and chair of the Department of Continuing Professional Education. Dr. Jafri has been the director of the World Gastroenterology Organization Karachi Training Center since 1998, chair of ACT Hepatitis Pakistan, member of the Guidelines Committee of the Asian Pacific Association of the Study of Liver, advisor to the Asian Pacific Association for the Study of Liver. He has also worked with WHO on the first HCV guideline. He was also the governor of American College of Gastroenterology in 2011. In 2018, he was awarded the prestigious award of Master of the American College of Gastroenterology. Dr. Jafri is fellow of many prestigious academies and colleges, including Royal Colleges of Physicians of London, Edinburgh, and Glasgow, and is also a fellow of the American College of Physicians and Gastroenterology. Dr. Jafri is also a member of many academies of sciences, and also the first Pakistani fellow of Farmer Institute. He has been awarded the Fellowship of American Association for the Study of Liver Diseases and the Royal Society of Tropical Medicine and Hygiene. I would not really take much of your time in introducing such a towering personality, but last, certainly not the least, let me tell you about his research contributions. He is a researcher of very high caliber. His citation exceeds over 12,000 and his H index is 51. I'm sure which is increasing with every day. With the stature of his science and the interest of work he has been conducting, his research has received wide appreciation all over. He also worked with College of Physicians and Surgeons of Pakistan in developing fellowship in gastroenterology. So as you can see that his expertise and contribution spread from education to community engagement and to medicine and treatment and managing healthcare institutions. I request Professor Dr. Wasim Jafri for his very interesting lecture to kindly resume this podium, please.
Thanks ever so much for being so generous in giving this introduction. I'm ever so grateful to Comstat, especially to Professor Iqbal Chaudhry and his wonderful associates who invited me to give this relevant talk on this COVID-19 pandemic. And as a healthcare provider, I think my job is related to what are the health issues associated with it. I hope everything is okay with the audio.
Clear and loud, but I would request the participants, which now exceed over 55, so please mute your mic, please, at this stage, because it's important that we should not have any echo during the lecture. So I appreciate your prompt action, please.
Thank you. There are no disclosures related to this talk, no financial or conflicts of interest. As an outline, I'm going to have a little bit about the general considerations highlighting the importance of this pandemic, and then go on to discuss specific health issues pertaining to lungs, liver, kidneys, mental health, and certain myths and reality related to what's happening in our community for this virus. And lastly, to discuss about the anti-COVID-19 drug development, and finally, conclusions. So regarding general considerations, certain dates are very important because it was end of the last year, that 31st of December, WHO was alerted by Chinese authorities of a strain of pneumonia in Wuhan. This was followed by, on the 1st of January, that where was it coming from? And they thought that Hunan seafood market was identified as the source of pneumonia, and hence it was closed. And then what happened was that, it just kept on spreading and spreading like a wildfire. In Pakistan, on the 26th of February, first 2 confirmed cases were reported, and the first death in United States happened on 29th of February, 2020. I gave a talk on this topic in May when the figures were the following. 16th of May, coronavirus cases were less than 500,000. The deaths were around 308. Followed by another talk in June when we had almost like double of that figure, 7,690,000, and the graph was going up with just under 500,000 deaths. And now this is what the dashboard is telling me from yesterday, when we had, according to the WHO, we have over 11 million, almost 12 million, and I'm sure today it would reach 12 million or already has reached that figure. And the deaths that have been reported are coming to, almost like 500,000 and above, which is climbing like anything. And you can see what's happening and who is contributing most. The Americas happen to have half of the COVID population reported globally, 6,125,802, followed by Europe, the Eastern Mediterranean, and the Southeast Asia. The Americas, North and South, as I said, is almost like 500,000 with 6,125,802 reported cases yesterday, followed by Europe. And the Southeast Asia, where we live, is 1,032,167, which is yesterday. So United States happened to be the most influential country when it comes to, influencing the rest of the world. They are reporting 3 million cases alone. That is 1/4 of the world population suffering globally from coronavirus reside in one continent, and we call it continent, but it's a country, which is USA, and this is almost 1/4 of the world corona population. India currently is almost reaching the figure of 1 million, and then what's happening below is that, in this list, Pakistan reported till yesterday 240,848. And as you can see that, the graphs that are telling us that, United Kingdom has stabilized, and that's why it's opening to rest of the world now. Mexico is still rising. Spain, after a havoc that happened in that country, has streamlined so wonderfully well, and the graph is reaching, almost at the baseline. Iran has, gotten lots of cases to start with, and then of course they have dealt it effectively, and they have plateaued, and there's a little bit of rise recently, but they are controlling it. Italy, in fact, we heard a lot about Italy, that, amazingly, in fact, the spread was happening, and now they are reaching almost the baseline. Hopefully, as we see the trend in Pakistan, we have reached the plateau, but who knows, the second and the third spike would tell us what. But the current figures really confirm that we might have, we don't know the reality, we might have reached the peak, and now there is a decline. So from yesterday, the government of Pakistan covid.gov.pk site confirmed 240,848, 90,554 active cases, almost 5,000 deaths. And so that is basically the most up-to-date data from yesterday around. Let's talk about what this virus is all about. Now, it belongs to a family of viruses that is known to us as coronavirus. They cause illnesses ranging from common cold to more severe diseases such as the MERS and the SARS. The first MERS case was identified in Saudi Arabia in 2012 from dromedary camels to humans, and the first SARS case was identified from China in 2002. It's, of course, an emerging infectious disease. We know in the last sort of almost like 7 months now that this is what we have to deal with it, and there is no end to it. Presently, mainly as viral pneumonia, respiratory-borne illness, and this is a common knowledge, but it has got varied presentations as we have learned quite a bit in the last 7 months. The spread is person to person, it's insidious. You can have it, and you don't even know about it, and that is the most situation of an asymptomatic infected person, and they can just be moving around us all the time, and hence we could be infected too and asymptomatic, and hence we may be the source of infection. So everyone, in fact, needs to be conscious of this fact that he or she may be potentially infected, and hence they have to look after themselves and others. There is a high degree of morbidity and mortality from COVID, almost approaching 1 to 3, but it can skyrocket, in fact, with the presence of other comorbidities. Devastating, particularly to subset of population, the elderly group, as we age and have other comorbidities like the heart disease, lung disease, diabetes, obesity, and liver disease. So if we have any other ailment going on, then we get this bug inside us. We had it, so we have to be very careful with the aging and other comorbidities. Don't forget, diabetes make everything worse, including this ailment. How the COVID-19 spreads. Lots of people talk about it. Everybody is an expert on it. Let's deal with it, in fact, with few bullets. There is much to learn about the newly emerged COVID-19, including how easily it spreads. Based on what is currently known, COVID-19, the MERS coronavirus spread is thought to occur mostly from person to person via respiratory droplets among close contacts. Close contact occur while caring for a patient. We, the healthcare providers at all levels, the beginners as well as the most experienced. In fact, the routines of life have changed drastically, and sometimes you may forget about putting on gloves or putting the mask in a proper way or whatever else the PPE, the personal protective equipment involves. Being within approximately 6 feet, where does the 6 feet came from? It is basically because people have looked into it, how far, in fact, the droplets can move. But with the air around us and the air conditioning, putting, all that fans and all that, this can move around for longer distances. Beware of this fact of a patient with COVID-19 for a prolonged period of time. Having direct contact with infectious secretions from a patient with COVID-19. So be alert about it. Infectious secretions may include sputum, serum, blood, respiratory droplets, even urine and fecal matter. If close contact occurs while not wearing all recommended personal protective equipment, the PPEs, healthcare professionals are at enormous risk of infection. And we've had so many colleagues all over the world who have suffered hugely as a result of this infection. Initial data about this infection came mostly from China, and we learned a huge deal. The proportion of severe disease increases with age. As you can see, asymptomatic, moving on to critical cases, the bars would tell you that as we advance in years, our mild and moderate gets less and less, and severe and critical illness, in fact, the proportion-wide, it increases. And so are the deaths. If you are critically ill, you are severely ill, the chances of dying from this infection increases, but you must actually not neglect the younger population. Now, this data came from China. In fact, in the earlier part of this pandemic, as we have learned more about it, even the youth can get into a critical shape due to this infection. So that doesn't mean that, in fact, people who have, who are less than 40 or 30 or whatnot, they should do whatever they feel like. So, but the current data still supports that as we advance in years, we have more chances of getting into ICU and into a critical shape. Now let's see what this COVID-19 virus looks like, graphically. It is, as I said, it is caused by SARS coronavirus 2, a positive sense single-stranded RNA. Belongs to the genus of beta coronavirus, which includes SARS coronavirus and MERS coronavirus. The genome is around 79% similar to the SARS and 50% similar to MERS. Now, the virus goes into your system. What can it do? It has to actually, it needs a receptor where it can bind all the spikes that you have now become very familiar for the configuration of this virus. It attaches itself to the ACE, the angiotensin converting enzyme 2 receptor via the receptor binding protein or domain RBD on the spike protein. It spreads predominantly by respiratory droplets. This is how it looks under the electron microscopy. And this comes from the alveolar type 2 cells from the lung. The spikes are quite vividly seen, and hence this photograph has become very, very familiar to even a layman, that how this coronavirus looks like. And it is just the receptors that I talked about, the ACE2 inhibitor receptors, are located everywhere, predominantly in the ciliate cells of the upper respiratory, alveolar macrophage type 2, enterocytes distributed hugely into the gastrointestinal tract, and cholangiocytes in the liver. So it utilizes the ACE2 receptor to infect human cells, and they are widely distributed in our body. The spike protein binds to ACE2 receptor via receptor binding proteins. Now, this is something to work on. Antibodies specific against RBD can prevent recognition of spike by ACE2. So neutralizing antibodies is the need of the hour, that we develop ourselves, or we have got a source where we can get, and this is just infused, and hence this virus would not be able to get into the receptor. Neutralizing antibodies bind to viruses and prevent infection of host cells. You have heard about these plasma therapies and all that, and that's how, in fact, the knowledge came about. Neutralizing antibodies against RBD have been identified in COVID-19 patients. They are a potential therapy for COVID-19, and lots of trials have gone all over the world about from plasma of patients who have recovered, and that has been given to patients in ICU, in critically ill, and miracles have happened already as a result of that. It is not uniformly effective, but certainly a major tool where it can make a difference. Non-neutralizing antibodies recognize and bind to virus, but do not prevent the infection. You may also have heard about a syndrome, the CRS, the cytokine release syndrome. It happens not in this, but in many, many other ailments, such as therapies with TCR cells and, in fact, cancer therapy and whatnot. So a cytokine release syndrome is a severe systemic inflammatory response that occurred due to a large uncontrolled release of inflammatory cytokines. These cytokines are beneficial as well as harmful to us, and hence, in this particular condition, in this storm, which means that the surgence of IL-6 cytokine, which can produce, in fact, lots of complications in the lungs and elsewhere when they are released out of proportion. So ladies and gentlemen, what's happening? The disease spectrum of COVID-19 is interesting to note. 81%, or let's say majority, were mild status. And this is stroke of luck, because in fact, if this would have been in fact in the severe or critical state, then we would have had it, in fact, globally, with the figures climbing over almost like 12 million. So 81% were mild, no pneumonia or mild pneumonia. This is an initial data from again China, but 14% was severe status, where of course the patient is dyspneic, the respiratory rate is hovering at more than 30, the oxygen saturation drops, the lung infiltrates more than 50% within 24 to 48 hours, and that produces the severity of the problem. 55% were critical ill status, needs mechanical ventilation, shock, complicated with other organ failure, and an ICU admission. The outcome of critical COVID-19 patients. So you can see between non-survivors and survivors, the difference really is between sepsis, respiratory failure, the acute respiratory distress syndrome, heart failure, septic shock, coagulopathy, acute cardiac injury, acute kidney injury, secondary infection, hypoproteinemia, acidosis. So all these things, in fact, when you look at people who did not make it, they are worse than compared to the survivors. So ARDS is, in fact, this is from the diseased patients who did not make it. The respiratory problem overwhelms, it's present in everyone. Type 1 respiratory failure, cardiovascular, acute cardiac injury, 77%, heart failure, 49%. Look at sepsis, in 100%. So by the time, in fact, they are in ICU and all that, they are so moribund that, infections overwhelm them. When it comes to other aspects looking into these disease patients, hypoxic encephalopathy, acidosis, alkalosis, hyperkalemia, shock, acute kidney injury, acute liver injury, and the disseminated intravascular coagulation is seen, in fact, in greater and greater proportion in patients who could not survive. So hence, from bedside to bench, we have got SARS-CoV, coronavirus 2. We are very familiar with bacterial sepsis. Here we have put up a viral sepsis. In fact, we have coined a new term. Pneumonia, respiratory failure, acute respiratory distress syndrome. This is the lung part. Acidosis and internal. When you have metabolic acidosis and internal environment disorders, the whole of the body, in fact, shakes up because of this problem. Acute liver injury, cardiac injury, and kidney injury. As you can see in this cartoonic version, this goes on in circles. Let me show you some of the photographs related to what's happening, in fact, in patients who suffer from severe to patients who could not survive. Look at the top line. You have a fatal case, first CT, second CT. The lungs really are solidified when you talk about acute respiratory distress syndrome. And instead of, in fact, the oxygen exchange, hardly anything happens. Even ventilating these patients would not reward you, as otherwise you may be rewarded. And in severe patients, as you can see, after recovery, there is still, in fact, the last photograph you can see, it still shows some infiltrates, but in fact, the fourth CT confirms recovery as the black areas get more, and that means that more air is now going inside and outside the lungs. God, Lord Almighty, look at the post-mortem pictures of people who could not make it. And this is coming from the lung, the right pleura, the left pleura, lung section, trachea, and the right lung bronchus. What are we seeing here? We're seeing pleural thickening, extensive adhesions with lung tissues, congestion, white foam mucus, solid. You just can't move it. Gelatinous mucus attachment in the trachea. No matter what can I do to get rid of this gelatin, it is just sticking like your super glue. And in fact, there is nothing that I can do to move it, and from the lung bronchus. When you see under the microscope, the pathological manifestations of right and lung tissue from a patient, look at the left one, which is COVID-19 pneumonia A. The right lung showed evident desquamation of pneumocytes and hyaline membrane formation, whereas the left lung tissue displaying pulmonary edema with hyaline membrane formation suggestive of early phase ARDS. So here you can see both ARDS and the early phase. So, now moving on to the liver involvement in ICU patients, it is universal, which means that so much is happening, in fact, in this patient with all kinds of drugs, trials, or otherwise, the patient has got hypoxia, his infection profile is high, so liver is affecting all the parameters that indicate, in fact, altered liver functions tests would be seen in patients who are under ICU care. And that's how the liver histological specimens would show under the microscope for patients who would not be able to make it. You can see massive portal vein dilatation. You can also appreciate sclerotic portal vein, thickening of the portal vein, and then CD34 staining decorating endothelium of dilated and proliferated portal vein. And finally, you can see these abnormal CD34 staining in sinusoids. So liver is affected grossly, microscopically in patients who suffer with the critical COVID infection. Further on, one can see sinusoidal thrombosis. Sinusoid is at the microscopic level, extensive hemorrhagic necrosis with sinusoidal thrombosis. Thromboembolic phenomena are also a common entity in COVID-19, serious, severe patients. Subtotal thrombosis of an enormously dilated portal vein and portal veins with subtotal recent. So this is the hallmark, I'm showing you photographs from liver, but the other organs are not spared like the kidneys and heart. In fact, wherever this virus has got this endothelium and it is there and it institutes thrombosis and all those blockages of blood vessels at the micro level and hence producing ischemic necrosis, which is there. So the Asian Pacific Association for the Study of Liver put up an expert panel thinking, what should we do? What advice we can give to our patients who suffer from this infection, because the data was still emerging. And I was part of this expert panel, and these are wonderful, wonderful colleagues, and I want to acknowledge all of them for having worked on this COVID-19 task force. And we produced a manuscript which is published in Hepatology International as a guidance for any one of us who want to learn about this thing. And what were the questions that we were trying to address? Are CLD, chronic liver disease patients, more susceptible to COVID-19? Do they have severe COVID-19 if infected? Outcome of chronic liver disease or cirrhosis after COVID-19, and care of uninfected chronic liver disease patients during. So some of these questions were put and we tried to address it. Gut liver have the second highest COVID-19 virus because the enterocytes, you can see, they are starting, in fact, the entire digestive tract has gotten, and the cholangiocytes, which is present in all the bile ducts, the micro level or the bile ducts at the major level, they're all cholangiocytes making the bile ducts, and hence they have. So second highest, the receptors where the virus would attach is in the gastrointestinal tract and the liver. Not known, it was not known previously, and we needed to address it. If compensated CLD or patients with hepatitis B and C, there's a global problem, are more susceptible. And what about the advanced cirrhosis with liver cancer, the autoimmune liver diseases like hepatitis and post-liver transplantation, susceptible are immune. So these were the thoughts that were discussed. And what was the data available for that? Abnormal LFTs in COVID-19, the frequency and pattern, as you can see, all these studies are coming from China in the initial part of our knowledge. And we know that they were on hosts of medications with antibiotics, all trial antiviral and antifungals were being given, anything people were thinking about, and hence the liver bore the brunt of all that injury by showing abnormal liver function tests. On admission, almost like 50% of the patient had evidence of liver injury, which rose to 3/4, 75.2% during hospitalization. And this is coming specifically, they looked at patients who were suffering from MAFLD or NAFLD, the non-alcoholic fatty liver disease, which itself is a non-infective pandemic. The whole world suffers from this type of liver disease, which is just related to obesity and giving more fat to the liver. And hence, the liver suffers. And whenever this subset of liver disease patients gets into problem through another infection, they are more serious. So this is seen in COVID-19 as well, that NAFLD patients getting into COVID have got more morbidity. The liver injury odds were higher with 9.04 and a confidence interval 3.19 to 25.1. The liver injury could be related to hepatocytes or mixed type of injury where the hepatocytes and cholangiocytes both are involved. Let's say the bile ducts are involved. So would the hepatocytes be spared, although they don't have any receptors? They cannot be. The pressure effects and all those bile ducts are very close. In fact, the micro bile ducts are just adjacent to the hepatocytes. So both types of injury is not rare. But the mixed type, which has got a higher odds ratio of 11.22, where both bile ducts and the liver cells are affected. Now, DILI, the drug-induced liver injury and COVID-19. Lots of experiments have gone into, people have, whatever they thought about the hydroxychloroquine, the azithromycin, you name it, people have tried these all kinds of drugs globally, not in the industrialized world, but all over the world, people have gone into various experiments, and patients are already on drugs for diabetes, for heart disease and all that. So there is certainly an element of drug-induced liver injury heightened in patients with COVID-19 because of multi-drug therapy. Polypharmacy has happened globally. And again, as I said, their patients already may have underlying liver disease and they didn't know about it. And this is not a rare entity. It's like an asymptomatic COVID. There could be an asymptomatic patient with liver disease which gets unfolded through an insult, through a trauma like the COVID infection. Fatty liver can sensitize liver to hepatotoxins, such as acetaminophen. The commonly known name is Panadol or paracetamol, something which a household would actually start to take with little fever or little aches and pains. So we also looked into, through the Apostle platform, we thought that, we need to address this group as well, where there could be a pre-existing liver disease is associated with poor outcome in patients with either this infection, SARS, coronavirus 2 infection. So this study was initiated by this group, and what were the conclusions? We immediately realized that SARS-CoV-2, the coronavirus 2, which is COVID-19 virus, infection causes significant liver injury in patients with chronic liver disease, decompensating 1/5 of cirrhosis, which was all right, a stable cirrhosis before, and worsening the clinical status of the already decompensated. The CLD patients with diabetes and obesity are more vulnerable and should be closely monitored. Atif Zaman, one of us, in fact, working in the US, he is a great talent. He produced this commentary in the New England Journal of Medicine and reviewed what existed on this subject. And look what his final comments on the existing data. This appeared on 3rd of May. This study indicates that COVID-19 patients with liver disease have higher risk for poor outcomes than those without liver disease. These elevated risks appear to be similar to those reported for other high-risk comorbidities, like I said, diabetes, heart disease, etc. Clinicians should consider patients with liver disease to be in the high-risk category and should follow guidelines for early isolation and timely diagnosis. So these patients could be, in fact, are routine patients in the clinic. But with this pandemic, we have to alert them by whatever means we have, because the clinics are not having that number of patients. The patients are at home. So through SMS, through WhatsApp, through media, no matter what the source one may have, we need to put, so if you are stable, stay at home and isolate and you will be better off. So the data confirms that if you have cirrhosis, no matter what the etiology is, alcohol, non-alcoholic steatohepatitis, B, C, hemochromatosis, autoimmune hepatitis, intensive care admission 23%, invasive ventilation 16%, death 40%. If you have only CLD without cirrhosis, you are better off, but still, look at 30% in ICU admissions, 27% invasive ventilation, and 12% death. If you had a previous liver transplant, again, you have to be extremely, extremely careful because your chances of having, in fact, landing into a severe problem, into intensive care, into invasive ventilation, and unfortunately not making it is almost like 22%. Again, there is an international registry addressing the same issue because liver disease is rampantly common all over the world. So people have thought about it. Okay, how do we actually take care of this thing? And look, this multivariate and a univariate and then multivariate tells you vividly that we have to be extra, extra careful. And as the liver disease progresses, from CLD without cirrhosis to Child-Pugh A, B, and C. These are the categories where the liver gets into, in fact, problems. A is better off than B, B is better off than C when you're totally decompensated, and the MELD score guides us towards the liver transplant. And you look at the p-values, they've all reported significance, so we have to be extra careful. And this is shown here on this thing, that case fatality rate percentage as the CLD, chronic liver disease, very stable, and then going on to cirrhosis in different categories, the case fatality goes as high as 60%. And in decompensation, again, the same scenario, liver disease stage CPA A, B, and C. So patients with liver disease have to be warned and carefully monitored and looked after. China also reported initially because their problem is hepatitis B. And what they reported was that patients with previous B infection and without previous B infection, there is more morbidity because they have liver cirrhosis, and their, in fact, chances of not making it was also statistically significant. So that is again a caveat we have to look. We have got an enormous B and D population, hepatitis B and D population, and these patients in fact are seen routinely in the clinics, and we have always to communicate regarding preventive measures and how they should look after themselves. I've already addressed about the non-alcoholic fatty liver disease and what is this doing, and from this manuscript that we produced, look at that there is pattern of liver injury everywhere, and the variables from the age to the male sex and the BI body mass index comorbidities, NAFLD, just mere fact that you have a non-alcoholic fatty liver disease, you have almost 20% chance of having a progressive disease from mild to moderate to critical and landing into ICU. If you have this problem of non-alcoholic fatty liver disease, what is there? Higher risk of disease progression. There is a higher likelihood of abnormal liver function tests from admission to discharge, and you are potentially more infected and shedding more viral because longer viral shedding time has been seen in this group as well. What about the liver cancer patients? Luckily, we do not have a lot of data on this thing, but cancer in general, again, we looked at some of the data published by Liang in early March from China. Patients with cancer deteriorated more rapidly than those without cancer. The median time to severe events was 13 days versus 43 days for patients who did not have cancer. So look into this thing. Yes, cancer in the body, and this is not something that we don't know about it. Patients are coming to our clinics, and they are amongst our, in fact, relatives and friends and all that. And if we have access, we must let them know that you need to protect yourself more than somebody who hasn't got it. It's not something that we need to depress them, but we need to address it in a very polite and gentle way, which is more effective than warning somebody. And of course, depression itself is a killer disease. So from our guidelines, we recommended that continue monitoring on and off therapy for HCC, the liver cancer, continue surveillance in those at risk for HCC close to schedule. You may delay for 2 months. That was during the lockdown period. Discuss risk and benefits of delaying surveillance. There are more risks than benefits. Postponing of elective surgery for resection or transplant or whatnot. This is a radiological intervention through invasive interventional radiology, the TACE procedure, and other procedures that we do routinely for liver cancer may be considered. So again, the level of evidence, as you can see, is C. So it's coming from expert panel because we do not have the authority of lots of research work in this field to guide you and produce a level 1 recommendation. liver transplanted patients, and they are in huge numbers as well for a hepatologist. They are not small numbers. Cases are reported from Italy in their pandemic when they were suffering hugely. 3 patients died of COVID-19. All were male older than 65. So long-term liver transplant recipients more than 10 years ago have got more potentials of a severe and a critical illness compared to short-term liver transplant patients because they are managing themselves reasonably well. So post-liver transplant, according to our guidelines, would be without COVID-19, do not reduce the immunosuppression medicine, which is their lifeline for the rest of their life. And COVID-19 positive, of course, we have to look after them because their immunosuppression could be a killer there as well. So we have to consider reducing their mycophenolate or the tacrolimus or cyclosporine dosages, especially in the setting of lymphopenia, fever, or worsening pneumonia. So they are managed. In fact, if there is a consult for us into that thing, we would take care of that entity as well. And those conditions with liver or without, which needs immunosuppression, without COVID-19, we must continue with their management. With 19, the reduced prednisolone and all these things that are listed here, that azathioprine, mycophenolate, or the calcineurin inhibitors dosages, we look at and modify according to our patient's need and its clinical scenarios. So initiate immunosuppressive therapy in patients with liver disease with or without COVID-19 who have strong indications because it is itself a condition that is producing more morbidity. So autoimmune hepatitis and graft rejection, one has to be careful in manipulating the things. So you have to start those treatment. In patients with COVID-19 positive, use caution in initiating immunosuppressive treatment where benefit might be outweighed by risks. So let's switch gears and go on to the kidney for a little discussion. Chronic kidney disease risk factor shown in meta-analysis from China for severity. The predictor of disease severity included old age, more than 50. I've already addressed that. Male sex, smoking, any comorbidity. So you have an heart ailment or especially chronic kidney disease, odds ratio 6.017, chronic obstructive pulmonary disease, if you are already suffering from asthma, emphysema, chronic bronchitis, 5.323 the odds ratio, and cerebrovascular disease, odds ratio 3.219. So you can see chronic kidney disease, the odds ratio is heaviest at 6.017. So patients who are on any kind of kidney disease have got a significant factor that they may end up having a serious problem due to COVID-19. Kidney as a target organ in COVID-19 infection, SARS and MERS-CoV infection, the AKI, the acute kidney injury, reported from 5 to 15% of cases with heightened mortality. The significance of proteinuria and hematuria is unclear, but it certainly means that the kidneys have been affected. You could have a glomerulonephritis or whatever. As a result of that, there is more blood and protein in the urine. So the novel COVID-19 epidemic in kidneys is addressed here, where people have looked into it, and kidney disease is now and associated with in-hospital death of patients with COVID-19. So it is not something that we can neglect. A rising creatinine is certainly a bad prognostic index for patients who suffer from this infection. So confirmed COVID-19, age more than 18 years, no maintenance dialysis, no renal transplant. The numbers are good, 701, age 63. So there is 16.1% in hospital death. Prevalence of kidney abnormalities such as what? Serum creatinine is up, serum BUN, the blood urea nitrogen is up, the electronically monitored GFR is less than 60, there is proteinuria, there is hematuria, and significant acute kidney injury. So clinicians should increase their awareness of kidney disease in patients with COVID-19. Ladies and gentlemen, we should never forget the patient as a whole. Mental death and COVID-19. Fear, worry, and stress are normal responses to perceived or real threats. And at times, when we are faced with uncertainty or unknown, There was, in fact, in March during the lockdown and even now. So it is normal and understandable that people are experiencing fear, and that itself is the start of multiple problems in the context of COVID-19 patients. Added to the fear of contracting the virus is a pandemic such as COVID-19 are significant changes to our daily lives as our movements are restricted in support of efforts to contain and slow down the spread of the virus. Faced with new realities of working from home, temporary unemployment, homeschooling of children, and lack of physical contact with family members, friends, and colleagues, especially when they are moribund in intensive care units and in fact in hospital, because access to the relatives is now not there, and that creates a mind-boggling problem for people who stand outside and wanting to hear from them, and they are inside, and communication link is through doctors or nurses. They cannot even see them properly unless there is a WhatsApp or FaceTime or whatnot. It is important that we look after our mental as well as our physical health. WHO has produced several, guidelines and all those things, and certainly we can have our own hospital-based guidelines. We should not create a dictatorial regime in that context. The relatives are not sort of, gone forever. Somebody who is sick inside an ICU and all that, I have seen huge suffering from those people who stand outside. And of course, whatever I could do and my colleagues could do, we can come out and discuss. In fact, even on phone, even in fact, a word of confidence, that really goes a long way from, in fact, from both the patient inside the hospital and the higher dependency units and the outside relatives and all that. This must be addressed by the managers of health facilities. They have to come onto the ground. And I have seen, in fact, within our country and other places as well, that people adopt their guidelines and do not look into certain aspects, which is itself a major creation of disease entities. People who are looking after children, older adults, people in isolation, and members of the public more generally to help us look after mental health. So we are all there to help. In fact, people who are listening to this talk of mine, in fact, I'm sure they are addressing all that, but try to be a little bit more sensitive on this issue, and you would do a lot of benefit to your patients and others. A word or two about the anti-COVID-19 drug development. This is state of the art. You have got so many targets. I've already said some of those. And what are those? The entry inhibitors. The virus is there, and if I have got something which inhibits it from reaching the cell, okay. If it can't reach the cell, it can't do much. Fusion inhibitors, once it has got the spike and there is a receptor and I've got something to stop it binding from them, okay, the virus would die off actually and would not do any harm to me. So fusion inhibitor. And then endocytosis, the virus is going inside the cell. So we have got to develop or think in, and the scientists are looking into it, the endocytosis inhibitors. What about the cell? The virus has gone into the cell and it has got those enzymes within the cell and so on. If I have protease inhibitors, I will halt the cycle of the virus from propagating. Then the RNA polymerase inhibitors. And finally, the cytokine storm that I was referring to, the IL-6 inhibitors clinically would improve my patients quite a bit. So we have, the remdesivir is the only drug so far FDA approved. It is not a miracle drug, but it is certainly, in fact, it doesn't reduce as much of mortality, but reduces the hospital stay in those patients from 15 to 11 days. And on this particular aspect, the drug was approved by FDA because there is a hurry to have something to treat. We want it, and drug companies are, trying their best to produce a miracle drug. Toxilumab has been there for us to use previously as well. Now it is available as an IL-6 inhibitor, and in the ICU setting, it has done good to our patients. Not always, but yes, it has proven success in some. So what about, this is a list of all those drugs, but absolute need is that we must be aware of drug-drug interactions of COVID-19. This is very important indeed, because Unless I know this drug and the others that the patient is using, and I've known hydroxychloroquine, the trial really started with very affirmative notes. It has been stopped by WHO and other agency. Maybe it's still happening remotely, but by legality, it is not there because of the QTC, and people have observed more deaths as a result of hydroxychloroquine group rather than the others. And so we have to be very, very sensitive of this aspect, that our patient have put our faith into us. We must not violate, and we should use all existing knowledge. Every minute, if it is changing, we have to address this issue. The thing is very important that, through our drug therapy, we should not bring more harm to our patient, and that is very important indeed. So ladies and gentlemen, we also have certain myths and reality. It could come through ignorance, or it could come through social media, because that is very active as well. And we should address this each time when we meet, in fact, our relatives, our friends, and our patients. Are hand dryers effective in killing the virus? So you put your hands in the hand dryer, frequently wash your hands and clean hands with alcohol-based hand rub. Once clean, dry them thoroughly by using paper towel or warm hand dryer. So without cleaning, without washing, putting your hands in hot air is not the answer. Can ultraviolet disinfection lamp kill the virus? No, ultraviolet lamps should not be used to sterilize hands or other areas of the skin, as UV radiation can cause skin irritation. You have to do it again and again. How many times would you do that? How effective are thermal scanners in detecting people infected with the virus? Thermal scanners are effective in detecting fever, not in the corona diagnosis, but it's used right, left, and center at the entry point. Thermal scanners cannot detect who are infected but are not yet sick with fever. This is because it takes 2 to 14 days before people who are infected become sick and develop fever. So you could be afebrile. So you put a thermal scanner and the person is let in. So fine, thank you very much, but he or she can still be potentially infected. Can spraying alcohol or chlorine all over the body kill the virus? Soak yourself in alcohol and chlorine. It's not going to do any good. But the way it's being done at outside the supermarkets or wherever you enter, there's a little spray, on yourself. It does nothing, but it is a gimmick. Is it safe to receive a letter or a package? This was a question asked. It is safe. What about, can pets at home spread the virus? Yes and no. At present, there is little evidence coming from some of the countries that it may. That companion animals or pets should be, such as dogs or cats, can be infected with this virus. However, it is a good idea to wash hands with soap and water after contact with pets. Remember this thing, it is still a good idea, so don't ignore it. They may be infective, if not from COVID, from E. coli, from Salmonella, and if that comes to your system in current pandemic, hospitals would not take you because you're febrile and you would not like to go in there. Protect yourself as much as you can. Do vaccines against pneumonia, the pneumonia vaccine, protect against the novel coronavirus? No. Vaccines against pneumonia, such as the pneumococcal pneumonia or Haemophilus influenzae B, HIB, do not provide protection against the new corona, but they would provide against the pneumococcal and all those. And if this is due for you, there is no harm in having it. Can regularly rinsing your nose with saline help prevent infection with the virus? No. There is no evidence that regular rinsing the nose with saline has protected people from infection with the new coronavirus. There is some limited evidence that rinsing the nose with saline can help people recover more quickly from common cold. That's the old thing. Can gargling mouthwash protect from infection from this virus? No, there is no evidence that using mouthwash will protect from infection from the new coronavirus, but mouthwash is a healthy thing. We should not neglect it. It certainly brings good to us because it improves the breath and gets rid of other germs. Can eating garlic help prevent infection with this virus? Garlic is a healthy food, no doubt, that may have some antimicrobial properties. However, there is no evidence from the current outbreak that eating garlic has protected people from the new coronavirus. But if you eat too much of garlic, you're okay. It will help social distancing. The smell that comes out may actually prevent people from sitting with you for 6 feet or whatnot. So indirectly, it could be helpful. Does putting on sesame oil block the new coronavirus from entering the body? No. Does the new coronavirus affect older people or younger people also? I've already elaborated extensively that older age brackets have more comorbidities and they have got more chances of getting into severity, but no age is immune. So people of all ages can be infected, and we know for definite now as more data has come in with Kawasaki and other type of illnesses in children, and they also go into, unfortunately, into ICU at this very, very tender age. So yes, we have to look after that group as well as seriously as we can. Are antibiotics effective in preventing and treating this virus? No. People have tried azithromycin and whatnot, but in fact, they do not work against the virus itself. The new coronavirus is a virus, therefore antibiotics should not be used to treat corona. The other aspects of antibiotics, the coronavirus patient may have infection as well, and if that is the source and your sputum shows those bugs or respiratory, then of course there is no harm. In fact, it would be logical to treat those bacteremic infections, but corona itself is no antibiotic role per se. Are there any specific medicines to prevent or treat this virus? To date, there is no vaccine to prevent, not yet, but you know it, that plenty of research globally is happening. The drug companies are pumping money like anything because it would be an overnight, in fact, success. So yes, we need the vaccine. The scientists are working actively, and we may have a good news in the near future, maybe by the end of this year or early next year. Only one specific medicine is recommended to treat the new corona, and I already referred to as remdesivir. It has shown to reduce the number of stays that the patient is in critical care from 14 to 11, but has not shown a promise when it comes to mortality for such group of patients. To summarize, what I've already emphasized is the disruption in global financial markets has been pronounced, and this is also to be looked at seriously because health economy has suffered, hugely for all those conditions that the governments were involved in. In Pakistan, we were after hepatitis B and C as a WHO signatory for 2030 elimination of hepatitis. This program is not halted, but certainly emphasis has been given to some other aspect, which is the need of the hour. You can't deny it. With minimal resources, you have to address an emergency rather than something which is going on. Anyway, the disruption is global. And if the cases and deaths continue to grow outside China, which they are currently, the markets stand to be affected adversely. United States, Europe, and other countries have imposed strict travel advisories and restrictions which will affect the travel industry, and it has. There have been school closures in Italy, the United States, Saudi Arabia, Pakistan, and other countries to slow down the spread and see what's happening with the education aspect. Many countries are using social distancing as a tool to control the outbreak. Saudi Arabia, for instance, has suspended visas for pilgrims wishing to go to Makkah to perform Umrah and Hajj this year. Italy took a page from China's playbook Sunday, attempting to lock down 16 million people, more than a quarter of its population, for nearly a month to halt, and they were successful. So yes, social distancing, these types of lockdown, they have got some positive aspects, no doubt about it, but there is a huge list of negativity comes in when it comes to human suffering in general for poorer countries and for poorer communities. So one has to address where a small house really has got 20 residents in it, and they need to be quarantined into that house. So, one has to look into all those aspects when an order comes out. One should not deny that this is the need of the hour, this was the need of the hour, and one has to take things in more totality. Finally, to conclude, COVID-19 has emerged as a pandemic with catastrophic negative impact on health and economic resources across the world. There is no denial about it. The disease is still spreading like a wildfire. The only successful story comes from China, although they have had a little second resurgence recently, but they have put Beijing into lockdown now in most of the areas. So what they can do, strict prolonged lockdown, which the rest of the world finds very, very difficult to continue. So there is still no satisfactory treatment. Remdesivir is only approved FDA drug, which is not available to most of the world. However, the generic brand may be available soon. The scientists are still struggling for the development of an effective vaccine, but enormous contributions are currently happening across the world. With global efforts, ladies and gentlemen, we should be able to overcome some of the negative impact of this epidemic, but this negative impact is going to go on for an extended period of time, and anybody's guess may be as good as anybody else's. So on a good note, do the best you can until you know better. And when you know better, do better. Thanks ever so much for listening to me.
Thank you very much. Thank you very much, Professor Jafri, for a fascinating presentation, like always. Our wonderful speaker has actually fascinated us, like always, and his lecture was attended by a full room, actually. The Zoom was actually full with over 78 people at some point of time. And I can see over 2 dozens of appreciative messages from different participants. So certainly a lecture which has actually taught us many very important aspects, lots of very specialized aspects of it. We have learned a lot about what preconditions of kidney and liver and mental health will eventually have effect on infections with reference to COVID. I can see lots of questions. There are 32 comments, and I think many of them are questions as well. But as I can see, the overwhelming response from everyone, and if I allow questions, then I'm not really sure whether Dr. Wasim Jafri would be available for quite some time. It would need at least an hour or so. So let me invite 1 or 2 questions from the participant in OIC countries. Okay, Professor Jafri, I think people would like their questions to be answered by you personally whenever you have time.
Yeah, I'm okay.
Sure.
So far.
So I want to conclude by saying that please do visit comstech's website. There are lots of information available about the initiatives which Comstech has taken recently in the general field of infections, virology, and COVID-19 pandemic. I would also like to say that every pandemic forces us to break our relationship with the past and to look into the world anew. So eventually a new world is emerging, and some glimpses of that new world was also included in the conclusion slide of Professor Jafri. Let's think about the new world and prepare ourselves for the next challenge. Thank you very much, everyone, for participating in this very important presentation. Thank you, sir, for an excellent presentation. Thank you. Thank you.
Thanks ever so much. Thank you very much indeed.
Sir? Sir, I have a question. Hello, sir. Are you hearing me?
I can hear you.
Yes.